Thank you everyone for joining us. We're so excited to launch this Community of Impact webinar series and have you with us. We started the Community of Impact. It's our spin on a community of practice, which is a group of people who work towards a shared passion or cause and learn from each other and work better along the way. And we are looking forward to sharing innovations and strategies from across the globe, like from our speakers today. And we would also love to build a network where everyone can share challenges and lessons learned from the community. For those of you who are new to IGH or not as familiar with us, we also wanted to start with a short introduction. So I wanted to introduce our executive director, Lydia Stazen, who's going to talk about IGH.
Hi everyone, it's so great to have you join us for our first Community of Impact webinar. I first want to say a particular thanks to Jeremy, to Dr. Surashree, and to IGH's Molly for being willing to join us today and kind of share what they've been learning around COVID-19 and data and the intersection. If everyone could please put themselves on mute, we're getting a lot of feedback, so just make sure that you got yourself on mute and that will help everyone out. Thank you. Also, I want to say thanks to Julia and to IGH's Reese and Tiffany for all the background work that goes into putting on a webinar like that. So, and also thanks to you all for joining us. We're so pleased to have you in the audience today and hope that you are all doing as well as possible in your contexts, whether dealing with the pandemic or protests against government or wildfires, as have now kind of been spreading across the United States. So thank you for taking time out. It's great to see some familiar faces here. I see John Darley, great to see you, John, and Jim Padden, and also one of my professors, Ramya Ramanath. So great to see and have you all here. We're really looking forward to a robust discussion through the question and answers, through the chat, and also through the presentations from our speakers. So we did just want to do a little brief overview of what IGH is in case this is your first experience with us. So we really have three strategic priorities, which we've put into some alliterative buckets of see it, solve it, and share it. So in our first bucket, we have see it, where we advocate for international homelessness policy that's really focused on definition and measurement. And this is important because we don't currently know the scope of global homelessness. I think only 107 countries track homeless data. Only 37% of those countries have recent data since 2017. And so for us, a really critical component of being able to end global homelessness is knowing what that is and having a number associated to that. And we allow for different country contexts. We know that homelessness looks different across contexts, but having that shared language and the numbers is going to help all of us in this movement to really take some steps forward in terms of ending global homelessness. Our second bucket of work we call Solve It. This is the work that Julia primarily leads, in which we partner with 13 cities in 6 continents that are really ready to take concrete action to end homelessness. And so the work that we do there with them is in deep partnership, helping them to set some specific targets around ending homelessness, working on the definition, the measurement, and then really acting as partners to facilitate and to catalyze progress towards those goals. So I know a lot of you on the call today are from those cities, and so again, we really appreciate that partnership and that work with you because all that field work informs everything else that we do. And then finally, we have our Share It bucket, and that is, really partly what we are doing today, where we want to connect with our global network, share the good work that's happening around the world, share the innovation, share the learning, sometimes even share the failures, because we know we can learn as much from failure as we can from success, to really build this sense of community and connection, and to drive this global movement forward. So every single day, our team is inspired by the work that you're doing, and are so grateful to have you part of this this movement and this community. So again, thank you for being here. I think Julia is now going to share a little bit more about how our hour today will unfold.
Thanks, Lydia. I just wanted to remind everyone to please put yourself on mute. This is a good function because you can see everyone on the screen, but we do need you to remember to put yourself on mute for the entirety of the webinar. If you would like to ask a question with one of our speakers, if you could please submit it via the chat functionality at the bottom of your screen. And if you want to share on social media and continue the conversation for this webinar, we're using the hashtag IGHCOI. So that leads us to introduce our first speaker, Jeremy Swain. So, Jeremy is an advisor for the United Kingdom government on homelessness and rough sleeping, and he's the former chief executive of Thamesreach, which is a London-based charity. So he has been working with the United Kingdom government throughout COVID-19 pandemic, and he's here to share some strategies about data and collective impact that he's learned around the way. And I want to thank Jeremy so much for being with us and for sharing your work.
Thank you very much, Julia, and hello to everybody. And I saw Indu somewhere on my screen. There he is. I like this waving on the screen, don't you? I know it's slightly weird, but and I feel so sad actually seeing people because of what we've been through. It's so tough, isn't it? And so dramatic. And although certainly there's been some fantastic successes in terms of helping people to escape homelessness in the UK, it has been traumatic. Actually, I'm sorry about the garish backcloth. It's not my colour scheme, it's my daughter's bedroom. And she's just come from, she's been in Mexico during the pandemic, where she did get COVID-19, but recovered well, and is now in Croatia. And it's just such a thing we've been through. So Indu, I'm looking forward to meeting you up with you again soon, mate. And thanks for all I've learned from you over the years. I just want to run through very quickly. I have to set some context for what we've done in the UK. So in March, with lockdown in this country, the government, and I work as a civil servant, specialising in homelessness within the government, decided that everybody had to come in off the streets in the UK. So that it was everybody in. That became the slogan. And over a week, the government said do it over the weekend, which was a big ask. It was done over a week, and 15,000 people came in off the streets, mostly into hotel accommodation during that period. A group remained on the street still, a smaller group, but it was in the end a very small number of people. We got in 95% of the homelessness population. I would say this too, caught up in all that were not just the long-term rough sleepers, but also people who were at risk of rough sleeping, and some people, let's be totally honest, who were probably sharing with friends at the time, but thought they'd take the opportunity to come into the hotels that were the primary form of accommodation. So in terms of the data that we've been using, we've always been strong in the UK about managing to get relatively accurate data on who's on the street. Okay, and we do that through a process through which the street workers put information onto a shared database, and that data is then aggregated up. So this is strongest in London, but it's also common in other parts of the country, in most of the main cities. So it's very easy to go to the data and get a figure on the numbers of people and their health issues, whether they have a drug, alcohol, mental health issue, the famous holy trinity of homelessness problems, and also data around nationality. Now, one thing about the nationality figures in this country are they're very, very important in terms of what you can offer people. So the UK still, for a short period now, part of the European Economic Union. People have the right to be in this country and from other countries, and they're here in order to get employment. So they have rights to come to the country and to find work. What they haven't got a right to usually is rights to claim benefits in order to get the housing benefits, as we call it, that you need to be able to maintain yourself in accommodation. So the nationality figures are really important. And in terms of the population of, roughly the population of London, over a third are from Central and Eastern Europe, particularly from Poland and Romania. And so the nationality figures are very important in terms of setting the plans that we have in place for people, which would be different for people from those communities than they would be for UK nationals. There's also a group of people that we call third country nationals, who are not European nationals, but are from other parts of the world. Again, they're not usually able to claim benefits. The jargon in this country, those of you like Lydia who have contact with the UK would have heard of no recourse to public funds. You can't claim benefits. So I note that as a very important bit of information. Having got people in, the data is mostly around movement. So it's very much not around activity, but around outcomes. And if I can just put on the screen, I've only just learned how to do this, so this is very exciting for me. Let me get this right. Can you see that? I don't know how clear that is for people, but this is a typical bit of data. We collect this data from all the different local authorities, as we call them, across the country. 326 local authorities. We get information about who's on the street, how many people are in emergency accommodation, and then importantly, because what we're measuring here is outcomes rather than outputs, what is happening. So this is the data from last week. You can see that there's a reduction in the number of people in emergency accommodation, which is fantastic. An increase, a small increase in the number sleeping on the street, currently at 894. And then we can show movements into different places. So move into accommodation or step pathway is essentially the accommodation provided by local authorities. Below that, there's a sense of what accommodation is still required. PRS stands for private rented sector. In this country, you can have council accommodation or housing association accommodation, or it can be private. And then at the bottom, this reinforces the importance of the information about nationality in terms of setting destination and outcomes for people. That's the no recourse to public fund information. And now I'm going to press stop share. Okay, so that's a really important bit of data for us. As part of the delivery of services, there was an amazing coming together of housing and health. So health are really key to what we're doing. And health are very engaged in increasing our knowledge of people, particularly in the temporary accommodation. So we have a form called CRISP, which is another data collection mechanism. And what's the health data is telling us is much more detailed information. So what an outreach worker can tell you is that somebody has a mental health problem. What they can't tell you usually, and our health colleagues are just interrogating this information, is whether somebody has a mild depression or whether they're psychotic. And so they're really just getting into the detail of health, and they're collecting that data so that when people move on from the hotels and the other temporary accommodation, they can get a health outcome and a package of support they wouldn't have got in the past. So this is now, if you like, dreamland for us, because we're bringing together different systems to get outcomes around health we didn't manage to achieve before. I think, to be completely honest, and I think it's good to have a candid conversation, we're a bit slow collecting that information. So the hotel group, obviously not a static population and busy moving on, they're not staying still to help us get the data. Very sensibly not staying still, they're moving on to other things. So that movement of people is very important. There's a very big program I've just been involved actually in making the decisions around the funding on, which is the 160 million program for this year to bring more accommodation in to help people move out of those hotels. So there's two really big areas in which we're collecting data and developing that data. It's never totally pure, and sometimes we're getting the data from different sources and actually measuring it across. And the health data is going to be absolutely key. Now, the government also every year provides information about mortality of homeless people. Okay, so it collects data using a number of different data sets, which comes from hostels, it comes from data to do with people who are defined as no fixed abode in this country, and from different places that will actually give you a sense of how many people have died who have been homeless over the year. So this is quite important. This information is watched and waited on with some trepidation by government. And last year I was actually with our key minister, Secretary of State, as he received that data. And in an hour after getting the data, he had to go and actually debate it in Parliament, which I thought was a really good sign of a democracy working. And it's such potent information. How many people in the homelessness population die every year? And last year, the figure, I think, was 562. But the UK government decided this year to actually look into how many people died of COVID-19 in the homelessness population. So again, using the same mechanisms, so consistency in terms of trying to find this information out. So what came out of that was, oh, going to the wrong one here. Is that the one? Have a look. Okay, this may be too small. I don't know whether you can read this, but this was up to June the 26th. So, and I'm not saying this is absolutely comprehensive, but it is pretty thorough. And as I said, it's the way in which the death exercise, if you like, the collection of statistics around deaths is done routinely every year. And I have to say, when I got this information, I felt rather emotional, because in the end, our work is about getting people into sustainable accommodation, of course, and improving the quality of people's lives. But it is very much about giving the people the chance to live. And when the figure came through that only 16 homeless people had died of COVID-19, then that was a figure that meant a great deal to me and to the team at the time. Now, this is June, numbers would have changed. This is in a country, of course, the UK, which has got a very bad figure around deaths. We've got one of the poorest figures in the world in terms of the numbers of people that died per million of the population. So as you can see from this data, mostly men, very small sample, only 16, fantastic. London and the north and the northwest, those who know the UK, that's mostly Manchester. And the average age of death, which won't surprise you, is higher than it would normally be in the homelessness population, because as we know, COVID-19 is very much based around the mortality rates, so at the steep end in terms of the age profile. So that's what we're doing, if you like, as government. There are just three things we're doing. So the general information that's coming in routinely from the local authorities being sifted and then being acted on. The information that's being collected by health colleagues, and then this national figure that we produce, and is one that really, as I said, is something that means a great deal for us and galvanizes us to action. So they're the three I would focus on. And I know we haven't got a lot of time, so I'll probably stop there, Julia. The other question you're asking me in advance is the coordination in terms of what we've achieved. The key thing is around health and housing coming together. What I would say also is health colleagues have been fantastic. Some of their projections have been wrong in terms of numbers, actually. So they predicted that at one stage we'd need 2,000 hotel bed spaces for people who were infected with COVID-19. And we opened up a hotel just for that group, 63-bed hotel. It didn't get more full than 18 people. So their projections about the mortality levels and infection rates turned out not to be anything near as bad as they turned out. So I'm sure we'd all agree, if you're going to get a figure wrong, that's the one. Fantastic, far lower than was expected. And I think I'll shut up then, because otherwise I'll gabble on too much and Lydia will be frowning at me.
Thanks so much, Jeremy, for that presentation. And I think it really shows the amazing work in the UK, and, you know, especially in your numbers, you know, the lower infection rate and the coordination with health to really keep people protected, move people into accommodation, and to, you know, during this unprecedented and challenging time, to make sure that people on the street were protected from the virus, and also having the coordination to move forward. So thanks so much. And if you have questions for Jeremy, please make sure to submit them in the chat.
I noticed, Julie, there is a question there. Do you want me to answer it now or later?
I think you can answer it now.
Okay, so the question is, thanks, Indu, for that comment. So it's showing how people on the street are counted. So what happens is, during the month of November, every year, every local authority in the country, all 326, go out and they either count on the street or they do an estimate. And usually they'd want to count. And if they're going to do an estimate, it has to be a very well-informed one. It's actually managed by an organisation called Homeless Link in order to achieve objectivity around the count. And this organisation, Homeless Link, challenged the local authority if there's any manipulation or accidental or deliberate in order to either make the figures too big or make the figures too small. And so we do what I know happens in parts of the United States and other places where it is actually a count. And it is also, so we can measure, you're going to miss people, of course, but you can do it consistently year by year, so you can measure the trends. And that's how we know at the moment numbers have been coming down for the last 2 years after consistently rising since 2010.
Great, thanks. And I think London, the UK counting is definitely an example for many communities. So I wanted to move on to our next speaker, Dr. Surashree Shome. She is a senior manager of effects and learning at the Azim Premji Philanthropic Initiatives, which is a part of a group of organizations and institutions founded by Mr. Azim Premji. The philanthropy is a great grant-making organization and aspires to facilitate a just, equitable, humane, and sustainable society with the support of organizations having significant potential to contribute to social change in a synergistic manner. Thank you so much for joining us, Dr. Shome, and she is going to be talking about her survey in one of the communities that IGH works with, Bengaluru, which is one of our vanguard cities. So we're very excited to have you and to hear your presentation. I think Dr. Surashree, you just need to, oh yeah, there you go, you're off mute.
Yes, thank you, Julia, and hello everyone. I'm going to present the study, and is it visible? Had I shared the...
It's visible. I think you just need to hit from beginning so it's full screen.
Yes.
Thank you.
Is it okay?
Yes.
Okay, so this webinar happened just when we completed a study on understanding residents of shelter homes in Bangalore. And so just for all of you, Bangalore is the IT capital of India. It's the capital of one of the state of the country, that's Karnataka. And it's one of the fast growing city of the country. So what I'm going to do is to discuss point from this particular study, which will highlight that how the data will be used to inform housing programs, especially for the homeless population in the country. So, as all of you are aware that India had adopted one of the most stringent lockdown process of 69 days, which has started from May 24th and ended on May 31st. That was the lockdown period that we say. And after that, the unlock period had started. And we had closed all the educational institutes, borders, all mode of transportation. So moreover, in a single word, that all the essential services, everything came standstill. So what happened due to this lockdown, restriction of movements and closure of most of the enterprises, especially in the urban spaces, had left lakhs of migrant workers without work and stranded in the city. Many started walking or bicycling hundreds of kilometers to go back to their native places. And this has been widely covered across by all the media houses, and where lakhs of, thousands of migrants are walking back to their houses for 100 kilometers. So, so to support at that time, to support these migrant workers, around 27,761 temporary shelters were opened across the country, this data has been released by Ministry of Home Affairs. And these shelter homes has not only provided the shelters, but also the food. Means the food is not only by the government, and sometimes some of the private donors and also the other institutes had supported these shelter homes to provide food and other essential services to these shelter homes. So the story of Bangalore is no way different. So like any other cities of India, the Bangalore has had a similar situation. Bangalore, which is also one of the, is the destination spot for most of the migration routes of India. Means if you can see, people has traveled, means if you're from the Northeast, which is something around more than 3,000 kilometers. So it is one of the most favorable destination spot in the country. And so what the administration did in the beginning is that they started accommodating these standard migrants in the available permanent houses, shelter homes. So permanent shelter homes, Bangalore have just 9 for a population of 1.3 crore. So certainly it got filled very fast. And then later they started somewhere around 100 temporary shelters across the city. There are many media reports that says that 100 are not functional and all those. So those are there. And but what the study that we did is in 10 shelters, of which 5 were from permanent houses, permanent shelters, and 5 are from the temporary shelters. So you can see this is a photograph, and this on the left-hand side is the permanent shelter. And you can see there are beds there, there is some mattresses there. But usually it is in one single huge room, and and there is beds are there are many, some which accommodate somewhere around 20 to 25 people. On the other hand is the temporary shelter homes, which usually had opened in some of the schools or some other spaces, public spaces. You can see that it is the school where they had started this temporary shelter, and you can see the boards and all those there on the background. So there is not much provision other than there is the sheet that you can see that where the people are sleeping, and there is some food has been provided. So Azim Premji Philanthropic Initiative, they had supported to provide dinner to all the residents of all these 10 shelters. And so let me tell you, the purpose of this particular study is not to understand or to assess these shelters. We were nowhere going to assess these shelters, that what are the services that they are providing. What we want to do is to understand the profile of the people. So the people who are staying in this, who had accessed this temporary shelters as well as the permanent shelter. The reason is that understanding this profile will help us design program and also advocate policies for them, because they are the people who are accessing these shelters. So the two objectives that are the purpose is that decrease the risk and vulnerability of the homeless or the migrant workers through improved interventions. And second is advocate for a favorable policies for the homeless citizens at the state as well as at the central level. So there's a very simple methodology that we have to use is the quantitative method, because as due to the lockdown, we were unable to get a enumerator who can travel and all those. So we have taken the help of the shelter coordinators there, and they were trained through Zoom only. We trained them 2-3 times, and there is a translation that happened. And just to remind you that, just to tell you that we did the study within 1.5 months. Means we started it from 16th of April and, sorry, 2.5 months. We finished it by the June 31st. We have submitted the report to our program team within this 2.5 months. And the whole team has worked together just to finish this report as soon as possible so that it could be used for the purpose that we are doing this particular study. So, so we have interviewed 457 people from these 10 shelter homes. And all the people, what we have said that all the people who were staying in the shelter homes from April 27th to May 3rd, when we have done the survey, all the persons should be surveyed. So that's how we have collected 457 people's profile from the survey. So these are the findings and the recommendations from the study. So you can see that this is the profile. So one thing is that the first outcome is that finding is that only 7% of our respondents are women. On the other hand, if you look at our census data, about 44% of the total destitute in the country are women. So that means very few women are accessing this shelter homes. And the reasons are known because of security and all those reasons. Also, there is a guideline that has been issued by National Urban Livelihood Mission of the country, which says that every city should have a shelter home exclusively for women. But Bangalore doesn't have it. So one of the policy recommendations that we have said that we have to advocate with the government to start some, to start a women shelter homes exclusively for them. And the second major outcome that you can see from the profile that something around 20% of the permanent shelter, the residents in the shelters are above 60 years. That is during the lockdown. And if we see the situation before the lockdown, something around 82% were above 60%. That means that majority of the residents in this permanent shelter homes are above 60 years. So what we have designed now in the program is that there should be a special geriatric care for these people. There should be a regular medical checkup for these people so that for the people who are above 60 years. Then if we, so these are the migration patterns. Certainly I can't go through by all the findings. So there are few things that I will like to highlight here is this the sixth point, that is the individual entitlements. So we have found that only 62% of our residents had an Aadhaar card. Aadhaar card is the unique identity number that has been given to all the citizens of our country, which have the biometric as well as the demographic data. So this card is now compulsory to access any benefits under the government scheme, whether it is a pension, whether it is a job guarantee under Mahatma Gandhi National Rural Employment Guarantee Scheme Act. So for everything, you have to have this Aadhaar card. And we found that only 62% of the people have Aadhaar card in the shelter homes. So that means that all the government scheme that has been started during this lockdown period to help these people would not be able to, means around 38% of our population from our study only would not be able to access it. And similarly, only 36% have their accounts in the banks or the post office. So then if you look at the other means it's also that BOCW, that is building and other construction workers card, which is available only with 6.7% of the construction workers who had been the part of our study. And there is a large financial scheme that has been started within this lockdown period to support these construction workers. But we know that most of them would not be able to access it because they didn't have this card that is compulsory to access this benefit. Similarly, this is about, because this is during the COVID, we have asked about their awareness, that how many people are aware of this particular pandemic. And so we have found that something around 91% of the people are aware of it. But there's a huge variation about the understanding about how the pandemic means how the COVID get transmitted, who are the vulnerable groups, what are the symptoms, what are the quarantine period, and what are the process, means whom to approach and what. So we have said there, so after that, there is a huge extensive awareness program that should be, that we had already started before. And we ensured that this is done in each and every, every shelter homes. But we are doing it, the philanthropy is supporting this particular activity from the beginning of the COVID in the shelter homes. Then there is another findings that I will like to highlight is that 58% of the residents have said that they would not be able to buy sanitizer regularly. And Similarly, 41% would not be able to buy masks to prevent themselves from the COVID. So we have said that mask and the sanitizer in the shelter home should be provided free, because they would not be able to buy it regularly. So in this cases, in this type of scenario, there is a probability of spreading in the shelter homes. So this is the last slide of the findings that I would like to highlight, is that there is a huge loss, economic loss, that has been, the country itself have more than minus 23% GDP. That's we have lost, and 62% of the residents, they have said that they have lost job because of the lockdown, and 45% have said that because they have to move out from their shelter to this particular shelter, so they have lost some of the positions. So these are some of the findings, and we have also recommended, the recommendations are in three spaces. One is for the government, one is for the partner who can incorporate it in their program, and also one is for the philanthropy, so that how we can also support other partners in this to fight against the pandemic for the homeless population. So this particular presentation is available with the IGH, and they would be, I think they would be able to share if it's needed. So there are some of the limitations that we have also said, that as we have used use Zoom links to train people, and also the enumerators, means we are not able to hire enumerators because the traveling was very difficult in this particular period. So we have asked the shelter coordinators to step in and to collect this data for us. So there might be some biasness in when it come to the services those are available in the shelter homes, but otherwise that one of the major feedback that I received from our shelter coordinators, that after this particular survey, they are able to understand their residents much more better. That's all. I think that I have taken more than 10 minutes.
Thank you so much for your presentation, Dr. Shome. It's fascinating to see the survey data, and I think it really underscores the importance of surveying and better understanding the clients that you're working with, and also the importance of disaggregated data, as you showed, understanding that women were not accessing the shelter because of security concerns, and then also the needs of the geriatric population, and designing services directly for those populations. So thank you so much. And if you have questions, just be sure to submit them, and then we'll have them at the end. So our final speaker is Molly Seeley, and Molly works for IGH as a special projects manager, and she has been with IGH since 2015, and she's been integral in developing and leading many of our initiatives, including starting our Place to Call Home program and developing IGH's online resource database, the Hub. So thank you, Molly, for sharing your research as part of your dissertation.
Hi, everybody. Julia, thank you for that introduction. I see a lot of sort of familiar faces on here, so it's nice to kind of see some of you again after a little bit of time here in the UK where I wasn't quite as involved. But I am going to talk a little bit, as Julia said, about the dissertation that I wrote for my master's in public policy and administration that I've been getting at the London School of Economics this year. And I'll sort of run through it very quickly, just as I'm conscious of time, but I'm, of course, happy to stop and kind of go over anything that anyone has questions about. So an overview of the project is I surveyed 22 cities to understand what their initial responses were to COVID-19. So especially during kind of the peak of lockdown, as a lot of really new interventions were taking place, I was interested to understand how homelessness systems were adapting to that, or whether they were able to adapt at all, and then kind of understand why some systems were able to do these sort of full overhauls almost overnight, and some really struggled to really make any significant changes at all. So I did focus on city processes rather than national or sort of hyperlocal, because I've sort of found that typically homelessness services are designed and run by municipal governments and NGOs, although obviously they might align with national strategies, especially sometimes to sort of receive fundings. But I started from this idea that the sort of normal service system setup has the bulk of its focus on kind of emergency intervention. So that's crisis shelters, day centers, food services, street outreach. And a lot of these services are congregate. So they would be, night shelters where you have lots of beds, kind of all in one room, et cetera, et cetera. And then the sort of smaller components of the system would be prevention programs and housing services. So I didn't get a ton into prevention programs within this dissertation, even though I think that's a very important piece of it, just because prevention programs kind of tend to have their own ecosystem, and it just didn't feel like there was quite enough space in the dissertation to give it the appropriate attention. So I wanted to recognize that some systems made a lot of changes to their prevention programs, but we aren't going to get that much into it. But of course, it was kind of a component. So the sort of key problem at the start of COVID was that government advice really focused on prevention and containment. And what that ended up looking like was kind of guidance around frequent hand washing, face shields, masks, closure of public spaces, bans on large gatherings, physical distancing, tracing, tracking, and then of course, self-isolation and quarantine. And these were really hard measures for most systems to put in place, especially where those systems were really heavily reliant on congregate shelters. In addition to that, obviously, people experiencing homelessness, self-isolation and quarantine is often just not an option. There's just nowhere to go. Access to, hygiene facilities is limited at best. And when they do have access, it is often in a congregate setting. And of course, problems around, people experiencing homelessness are often, immune deficient or may have other sort of health problems that make them more susceptible to COVID. There was a really great quote from Dr. Jim O'Connell, who works in Boston and was sort of spearheaded Boston's response, that said, the pillars of viral containment and treatment, physical distancing, frequent hand washing, quarantine, isolation, and sheltering in place are rendered futile, if not impossible, when viewed from the lobby of a crowded shelter, which I think kind of just does a pretty good job of summing up what the issue for a lot of systems was. So with that in mind, I talked to 22 cities to basically try and get under what they did to attempt to kind of fit into this guidance and make some changes. So as you can see on this slide, I developed essentially just a spectrum of city responses. It should be noted that no city really falls perfectly into any one bucket, and often they'll have kind of sort of little bits of different ones, but they've been sorted into where they're kind of a best fit. So on one end of the spectrum is a weakened system. So essentially a weakened system is a system which got notably more difficult for people experiencing homelessness to access services. And when I say access services, I'm sort of holding them all to whatever their status quo was. Of how they would have accessed services before, and also typically included an element of criminalization, which might look like fines for being out in public spaces during shelter in place kind of measures and things like that. A no change system. It's a little bit tricky to have absolutely no changes because obviously there were broad citywide changes. So for a no change system, I'm sort of including things that would be, there was no change made to the homelessness system specifically. Staff might have been wearing masks because that was required across the board, but there were no special measures sort of targeted toward homelessness services, people experiencing homelessness, or the sector at large. An expanded normal service system is one which took all of the services that it was already offering and just kind of bolstered them. So that might be more spaces, sort of more congregate spaces. It might mean sort of an increase in protective gear, or more outreach, more food runs, increased kind of access perhaps to nurses or that kind of thing, but really didn't change the direction that the services were pointed at. So it was really just kind of bolstering a system and not making any sort of changes to its ethos or how it operated. Broadened services is systems which bolstered their normal services and added sort of COVID specific interventions. So the most obvious one that I think is kind of a great example is medical street teams. So cities which implemented kind of COVID specific testing and tracing, medical street teams where they would often go into encampments or congregate settings and had really sort of specific measures for that, as well as, sort of quarantine centers for people experiencing homelessness. But these often were also congregate, but it was just, you would only go in if you had already kind of tested positive for COVID. So it was kind of a medicalized approach in that way, I think, insofar as it was, giving more resources to what they were doing, plus adding elements to kind of contain the problem rather than sort of trying to prevent it, just saying, well, we know it's going to hit and we're going to do our best to make sure that it has the sort of minimal impact. And then finally, on the sort of other far end of the spectrum is a system overhaul. So a system overhaul, I sort of have categorized as cities which completely changed or, sort of significantly changed the direction of how their homelessness services operated. So even though there are a couple of cities within that that left their congregate shelters open, the sort of intervention direction of how they responded to COVID was much more in the direction of housing-led and preventative. So looking to say, how can we actually address why people experiencing homelessness are so vulnerable to COVID, rather than, how can we sort of mitigate the effect that COVID is going to have on these populations. So I know it was a real sprint through that, but I hope that everything sort of made sense. Oh, let's get that last animation up. There we go. So I wanted to pull out sort of 3 key pieces of learning that came from it. Obviously, it's quite a long thesis, so these are just sort of some of the kind of key pieces I thought that you guys might be interested in. So the first one, as you can see here, is coordination. So I think one of the really, really key pieces is that for systems who really shifted to looking at addressing kind of root cause rather than mitigation, there was very clear leadership that was coordinated between both sort of city officials and kind of homelessness experts. So this was done typically on a task force or, kind of a joint committee where you had both of those perspectives come in, and then you had really clear directives that were homelessness specific. So they weren't just, broadly everyone should wear masks and, physically distance. It was, in congregate shelters, you should do X, Y, and Z, or you can't have congregate shelters anymore, and this is how we're going to, implement a different path, I guess. So that was something that was really important. I think particularly in weakened systems and no change systems, you often saw there was kind of no guidance given, or guidance that came really, really late and was a little bit ad hoc. So it proved really difficult for systems to kind of efficiently implement any of that advice. Data and measurement, I think, was also really important, particularly for tracking and tracing, which I'm sure seems very obvious. I think as it turned out, the size of the homelessness population prior to COVID seemed to not necessarily steer cities into any one direction. So I do think it sort of showed that the larger the population, the kind of more likely they were to do kind of broadened services or expanded normal services rather than an overhaul, but that's not 100% correct. I mean, the cities that did overhaul had a pretty wide range of population size, and there were some cities that were no change systems that, you know, also had various levels. I think a great example is, you know, in Helsinki, where they didn't make massive changes because I think probably the argument is that they didn't really need to, because they were already doing a lot of the stuff that system overhauls began to do at that time. So actually, one thing I did mean to say earlier was that the spectrum is not designed to be, you know, from worst to best in any way at all. It was kind of what worked for each system, and different systems, you know, certainly had different needs and were effective in different ways. And then this kind of new resources question is one that I was really interested in going into it, which is, I think there's often this idea within the sector and within most nonprofit sectors that the more money you have, the better your response is able to be. And actually, I think that we sort of saw that wasn't necessarily true insofar as getting more resources did not steer cities specifically toward any one type of response. So I think it's really ended up being more about the attitudes people had toward what effectively addresses homelessness itself, that COVID then kind of provided, you know, sort of a stepping stone to move that forward. So in cities which did switch to kind of housing-led interventions, you can see that before that, a lot of those cities were already talking about the value of kind of housing-led approaches, whether or not that rhetoric was being sort of operationalized. So I think in that sense, COVID really provided the opportunity for a collaborative leadership group to say, actually, this is the sort of stream we need to take. And in cities where that is sort of less of a pre-COVID rhetoric, it was much harder, I think, to make that argument. So that is sort of the sprint through it. I know we went at kind of breakneck speed, but I wanted to make sure there was time for a little bit of questions and just to be conscious of not running over. So thank you.
Thanks, Molly, for that presentation. And I like how you underscored how important coordination is, you know, before the pandemic, and how it really carried through to providing, you know, a direction, and, you know, the coordination between different sectors was very crucial in the cities that you surveyed. And Molly's dissertation, you know, we'll be sharing it on our website, so that if you're interested and want to learn more about each city's response, it will be available. So I think we have some time for a few questions. So I have one question for Dr. Shome, and it was about the role of advocacy in engaging the data collection, and how the role of different stakeholders was leading it.
Sure, Dilip. So should I start from your question, or should I start from other questions? Because I have seen that media has also added one question here, and there are another one or two questions.
I think if you want to start with my question and kind of do the other questions, or whatever question you feel is most relevant.
So yes, so data collection, that as you said, that how we did it. During the lockdown, as I have mentioned, that any type of traveling was not possible. So, but we have our partners there who are working in these shelters, all these partners that, so what we did is we restricted our study to 10 shelter homes, all of them 5 permanent and 5 temporary. Just to add here, there are just 9 shelter homes in Bangalore. Of that, 5 is supported by Azim Premji Philanthropic Initiative. for, means we give small grant for some of the services in the shelter homes. So in the permanent shelter home, and temporary shelter home, which started somewhere in the month of March or April and ended on June 10th, because June 10th government have stopped all the temporary shelter homes. So in this period, the traveling was not possible. So we took the help of shelter coordinators. We have a Zoom meetings. We continuously we are discussing our study, the questionnaire, all with our partners, including the shelter coordinators. So we did the piloting. We asked them to fill the questionnaire for 2-3 residents there, and then share their experience. And based on their experience, we have again redacted the question, finalized it, and then we monitored it for because as soon as they have filled it, they have put it in the Excel sheet also. We have checked the data there, the data hygiene there. And there we have our consultant, Ms. Rajni, who has translated it and then explained it 2 times to our shelter coordinators, that the meaning, not of the meaning of each question, but also context of each question. So that helped us. That helped us a lot. And another thing is the sampling. That sampling was not because at that time there was not much flow, but after May 31st there was a flow, because the government have started the within the state bus services. So there are a certain number of people who are going back to who got the buses. They got took the bus and went back to their home. And there is a certain number of people who again got evicted from their workplaces and they entered the shelter homes. So what we did, that we said that during the period of the survey, all the people who are staying in the shelter homes should be the part of the study. So that's how between this period from 27th April to the 3rd May, all the people who are who are residing in the shelter homes were surveyed. But certainly there is 1 or 2% drop, because 1% I think, because we have also asked that whether they are willing to. So 1% people have denied, and they were not the part of the study. So that's about the data collection. And then there is a question from the Lydia, that what kind of interaction between the health ministry and the housing ministry that's going on. So let me talk about the Bangalore city. So in the shelter homes now, the government has provided 3 times food. They have for free, because most of the people, they are not able to go for a work still now. Enterprises are closed. There are less opportunities still now in the city. So there's a free time, 3 times food is provided. Other than that, there is a regular health checkups that's happening in the shelter homes. So like on 15th August, there is one person who has been identified as a positive case. And as soon as he has been identified, he has been shifted to a government hospital, because isolation is not possible in this shelter homes. So as you had seen the photograph, that all the 20 people are staying together in one shelter home. So it is not, isolation is not possible. So the person has been shifted. There was again, all the people have been checked. And thank God that no one else has been found. So, but there is a regular checkup there. Thirdly, I'll still say there are certain issues, like as I have mentioned, there's something around 20 to 30% of the people who are in the shelter homes are above 60 years, who are most vulnerable in this particular type of pandemic. We can't give them a isolation space also. And many of the people, they are started going outside to do some work and all those. So the government is trying to have a regular checkup, but isolation is not possible here. So that is what I know about the Bangalore city. About the second question I still remember is about that, what is the nature of engagement? Let me go through by the question. I'm really sorry.
I think that will probably be the,
yeah,
if you
from Ramya Ramnath, that So the advocacy issue means this particular study certainly was meant for the for Bangalore, and we are going to advocate the issues those were there, like more shelter homes in the city, exclusive shelter homes for the women, and there should be a geriatric care or at least a regular checkup and all those type of things. Those are there in the presentation. But for we are also going to do a study, means it's not a study, a policy paper for the center, which would be advocated at the central level. And as I was saying, that the study is not enough. We have to get collaborated with the other players who are working in the different cities, who are working from a long time in this particular space. We have to work with them. So we are planning to get it out by another year, to have a country level policy paper for the homelessness. That's the second part. And
I think we're a little over time, so I want to be,
yes.
but thank you for so thoroughly answering everyone's questions. And we will be sharing additional resources and also notes and a blog from this presentation, and we're planning to share the recording if anyone wants to go back or share with a colleague with our on our website and hopefully on our YouTube channel. So I think because we are out of time, I did want to we'll be sharing additional resources to answer questions, and we are also going to be to be sharing on social media, and then also we're going to be starting a Community of Impact Slack channel. So if you have additional questions, we'll be sharing the link in a follow-up email, so you can join and share your data strategies and how your community has used data and collective impact to kind of go through COVID and to have innovations and strategies to really house and protect homeless populations. So please, share and connect and continue the discussion offline, and then we'll be continuing our webinar series and sharing, new dates in the future. So I did want to thank so much our speakers for taking part and sharing their amazing work in their communities, and to highlight the importance of data and coordination to really get through this pandemic and to be a leader in providing support for rough sleepers and the homeless. And I also want to thank everyone here for joining, and please be sure, as I said, to connect, and we'll be in touch on Slack and other social media channels. So it was great to see all of you here for our first Community of Impact webinar, and we look forward to continuing in the future. So thanks again to Jeremy, Swain, Dr. Shome, and Molly for their presentations, and I think that's it, and we can sign off.